Namaste and good afternoon. Welcome to the Conquer Cancer series presented by Apollo Hospitals. This is Dr. Srinidhi Chidambaram and I'm very happy to see you all again. The focus of this Cancer is Conquerable series is going to be a set of topics that are designed to create awareness and to help you to understand all about a complex disease that evokes so much of anxiety and concern in us, which is cancer. But we are going to help you to be aware that cancer is conquerable, provided you pay close attention to early warning signs, take screening tests, and take active steps to reduce your cancer risk wherever possible. Detecting and treating cancer early can help to cure the disease. And today we are going to discuss a very well-known and common organ-specific cancer, prostate cancer. The prostate is a small walnut-shaped gland in males that produces the seminal fluid that nourishes and transports the sperm. Prostate cancer is one of the most common types of cancer. Many types of these cancers do grow slowly, but some of them may need very minimal or even no treatment, but other types are a bit aggressive and can spread quickly. So prostate cancer is definitely one of the cancers that can be cured when it is still confined to the gland, which means that it needs to be detected early. So it's very important to know all about this cancer and also about the latest methods that are now available to both diagnose and treat it. To discuss this, I'm very happy to welcome Dr. Sanjai Addla, a consultant urogynecological surgeon and robotic surgeon at the Apollo Cancer Center at Apollo Hospitals, Hyderabad. Dr. Sanjai Addla has spent the last 18 years in the United Kingdom, following general surgical training and MRCS, and then he was trained in urology with an FRCS, and then underwent specialist uro-oncology and robotic surgical training at the Christie Hospital, Manchester, and a fellowship in Brussels. He has been a consultant urological surgeon at Bradford Teaching Hospital and has had extensive experience in robotic surgery and is recognized as a mentor by the Intuitive Surgical Company and has trained many teams in England, Europe, and India, performed more than 450 robotic prostatectomies and 150 robotic partial nephrectomies, hundreds of other surgeries, and extensively published several papers, won many awards and grants from various societies. He has made over 36 international presentations, over 18 peer-reviewed publications, and was invited to the British Parliament discussion on access to robotic surgery in 2015. Welcome, Dr. Sanjai Addla, to this Facebook Live discussion. Thank you so much for being here. So let us begin with an overview about what is prostate cancer and why must people know about it. Over to you.
Good afternoon, Dr. Chidambaram. I'm just going to answer those questions. So why do we need to be spending any time knowing about prostate cancer? Because it is very relevant to us. If you take the example of any Western society, 1 in 5 people, 1 in 5 men are affected with prostate cancer. Prostate cancer is the commonest cancer afflicting men in Western societies. And what we are seeing is in India, with more and more westernization of our lifestyle, our diet, and our eating, other activities, which is whether we are spending more sedentary life, we are seeing that there has been an increase in the incidence of prostate cancer. So that's the reason we need to be knowing about prostate cancer. What it is, straightforward, it is a cancer involving the prostate. But what we have seen since I've moved to India is that prostate cancer in India is much more of a killer disease compared to what we have seen in other Western societies and especially in UK where I used to work. So there is quite a lot for us to further learn about prostate cancer in India. And of course, we need to be making sure that the patients and general public are aware about prostate cancer. That's the reason why we should be spending this time knowing a bit more about prostate cancer. The summary would be to say, how are we doing with respect to knowing about it and how are we doing with respect to conquering this prostate cancer? The awareness is a lot more compared to what it used to be. Because if you see the incidence of prostate cancer, take the example of the metropolis, Delhi, Pune, even in Calcutta, prostate cancer is the second commonest cancer in men in India. So it is not something that is unusual. We are seeing more and more of it. That's one. Are we winning the war of making the people aware about it? Yes, again, I would say there has been a positive impact, because like with any cancer, the initial symptoms of prostate cancer or initial symptoms of any cancer are very subtle, very mild. So you need to be aware of them so that we can pick this up early, so that we can cure them. So if you take the example, let's say 5 to 6 years ago, wherein we were detecting 70 to 80% of the cancers in already very late stages, we are picking up cancers in earlier stage. So awareness is working, but still we need to be pushed on a bit more about it. And the last one, are we doing well with respect to managing prostate cancer, detecting prostate cancer, and most importantly, curing prostate cancer? And the answer to all those is definitive yes. We have made more progress in the last 5 to 6 years in management of prostate cancer compared to what we have done in the previous 50 years. So there has been a groundbreaking shift in the way we are managing prostate cancer. Compared to a patient coming with the same disease in 2015, at least I can say we have doubled their lifespan now. So in the last 5 to 6 years, the patient presenting with advanced prostate cancer, if I could say that they were alive for 3 to 4 years before, now I can say they are alive for about 6 to 7 years. So we have managed to double their lifespan, which is a huge incremental benefit we are seeing. And this is down to new investigations, new treatments, new molecules, and people being aware so that they are coming up early to us. What we are going to do is ask some specific questions that have been raised by other viewers so that we can highlight and emphasize on the things that are important for general public.
So to begin right at the beginning, where is the prostate gland, and what are the types of cancer? Is it all the same type of cancers, or are there different cancers that can affect this gland?
So prostate gland, as you in your introduction you said, it is there from the birth of everyone. So nobody acquires a prostate gland; it is always there. And the second is it always increases with age. So if somebody has a graying of the hair, becomes a bit more old, they develop arthritis, we know that their prostate will be bigger as well. So prostate gland becoming bigger, we know is age related. And the same we can say with respect to prostate cancer. What I mean by that is, let's say we take 100 people who are 60-year-old, around 60 of them will have prostate cancer. So prostate cancer is very prevalent, but only 2 to 3% of them will be symptomatic, and only 2 to 3% of them will further progress and are going to die of those prostate cancers. So the objective is to identify those 2 to 3% of the people, not the 60% of the people who will harbor prostate cancer without affecting them. So prostate gland is at the neck of the bladder, where the water passage comes out of the bladder and becomes the water passage. That's where the prostate is. And when it increases in size, it causes a blockage to the urinary tract, thereby causing the problem of difficulty passing urine.
So there is this prevalent view, and you were saying that that's not always the case in India, that prostate cancer is very slow growing, very benign, and I mean, not benign, but it's much less aggressive compared to other cancers. So what would you like to say about it, and what is different in India?
I think the way we describe India, which is that it is a subcontinent, is the right word to describe it, because we are not a single country. We have got huge ethnic variation. We have got huge variation in our dietary habits and our lifestyles. And prostate cancer is a lifestyle disease. So it isn't that what is relevant for people in North India, somewhere living in Kashmir, it's not relevant to somebody living in Madurai in Tamil Nadu. So it's very different. So the prostate cancer, that's the reason the example that I give is in Metropolis. Metropolis, wherever the lifestyle is closer to the Western societies, that's where we are seeing a huge increase in the incidence of prostate cancer. The Mumbai Cancer Registry is one of the best maintained cancer registries. And what we see is that the data from Mumbai is totally different to what they have Mumbai rural area. The cancer incidence is much lower there. So prostate cancer is variable within India. Then the next question, are we seeing more aggressive cancer in India compared to what is known in Western societies? Health system as well as the diagnostic pathways in India are about 2 decades behind where the Western societies are. So we are picking up what Western societies picked up in late 90s. So they picked up huge number of prostate cancer, which is what we are doing now. And hopefully once we have dealt with this, we understand it better, then we'll be able to say, okay, who are the people within India who are developing aggressive cancer? Then what I mentioned about prostate cancer in India being more aggressive is the ones who are coming with symptoms to us, to tertiary referral care, we know that all of them are aggressive. The problem is we are not picking up cancers in the community when they are asymptomatic, which is what is done in Western society. So proportionally, we are only seeing high volume cancers, aggressive cancers, metastatic cancers. So when you look at it that way, you say that, oh, prostate cancer is a much more of a killer disease. So it is what we call as a sampling error that we are seeing. And there is a huge bias with respect to patients coming to tertiary referral practice because we don't have that good a data. But are we different genetically? Yes, we are. So we need to study prostate cancer in Indians for us to know what actually it is.
So what would be, the earliest warning signs, or, how can this be picked up early?
The answer is we can't, is the straightforward, which is I'm not even answering your question. The only way we can pick up any cancer is by screening. Screening is when the patient is asymptomatic. So though we tend to say that, okay, patient has got problems with the urinary tract, patient has got pain in the bones, it's already late. Prostate cancer has already left the prostate, has gone to the bones. So only by screening. So whom do we screen? Screening is quite easily done with a blood test. And anybody above 55 to 60, that's when we tend to pick up the cancer earlier, or we tend to pick up cancer more often. So if they approach for a blood test called as a PSA, if we start picking up an elevated PSA, then we can investigate. So that is what you call as screening for prostate cancer, which isn't a government policy anywhere in the world. So I'm not advocating that everybody does it. But if you are looking at mild symptoms, which are generally related to prostate enlargement, which can be related to cancer of the prostate, is passing urine more frequently, difficulty passing urine, waking up in the night time to pass urine, the urine stream stopping and starting, and after finishing passing urine, they feel that there is some urine to come out. So these are the symptoms wherein you know that there is some blockage to the prostate, are probably the earliest symptoms of prostate cancer.
Talking about the screening, though it might not be the government policy, but in several of the health check packages, we do have the doctor, the surgeon examining the person for the prostate surgical exam, as well as PSA is there in some of these packages. So do you think that people at what age should start doing these annual screenings?
Currently, I would say anybody above 55 who got that's when you would consider doing health screening, because currently still the commonest problem that we have is cardiovascular disease. So along with your cardiovascular, do think of the common cancer, and the common cancer in that age group tends to be prostate cancer as well. So the general health screening with respect to cardiac and cancer screening, colorectal as well as this one.
So once there is prostate cancer, is there, what are the different stages that can happen?
I think you can use this, though we don't tend to use the same description for stages. Any cancer, if you say the stage 1 would be the cancer that is within the prostate. Stage 2 would be the cancer that has just gone out of the prostate. Stage 3 would be that has gone to the regional lymph nodes. So it hasn't spread everywhere else in the body, but somewhere in and around. And stage 4 is where it has gone out everywhere in the body. So the management for stage 1 and stage 2 is to cure the patient of the disease. Stage 3 is to make sure that they have a very long life though prostate cancer will be the reason for their shortened lifespan. And stage 4, you're almost controlling the damage to ensure that they don't have symptoms from this advanced prostate cancer. So though we use that other technical way, I would probably, for management purposes, that's what would be the staging of the prostate cancer.
So we spoke about the PSA test. Apart from that, are there any other investigations? What are the next level investigations that are done once there is a suspicion for prostate cancer, or if the PSA is elevated quite a
Though we always tend, there are two ways of looking. Can you have prostate cancer with normal PSA? The answer is yes, but the proportion of them is very small. So we can say that majority of the time, 90% of the time, if there is a prostate cancer, the PSA would pick it up. Yes. So if someone has an elevated PSA for their age, then the next step would be a clinical examination to determine how the prostate feels, done by a specialist, normally a urologist. And depending on that, the current guidelines are we do an MRI scan of the prostate. MRI gives a very good understanding of, is there a cancer within the prostate? If so, what is the volume of it? Probably what is the grade of it? What is the extent of it? And then we tend to do biopsies of the prostate, which is just taking a true cut specimens from the prostate to give us an understanding whether there is a cancer or not.
And once it is diagnosed, what are the methods used to treat prostate cancer?
So again, it depends on the stages of the prostate cancer, as would be the case with any cancer as well. So let's look at the prostate cancer. We tend to use the word saying that there are more people who die with it rather than because of it. In that, when I'm saying that 70% of 70-year-olds will have prostate cancer, all of us know 70% of 70-year-olds are not dying of prostate cancer. So prostate cancer is very prevalent, but it isn't a cause for the shortened lifespan. So the first definition that we tend to do is this a lethal cancer or not? Or what we tend to say is, what is the risk? The risk of this prostate cancer shortening the lifespan of the patient as well as the lifestyle of the patient. So we use few characteristics of the cancer to determine, is this a low risk, intermediate risk, high risk, or very high risk. We use PSA, we use the Gleason score. Gleason score is how aggressive the cancer is. And then we tend to use the clinical stage, which is by examination and MRI scan, and then put them into this category of low risk, intermediate risk, high risk, very high risk. And normally for low risk, we can just keep an eye on the cancer, because even if we treat them, even if we don't treat them, the chance that they will die of that prostate cancer is 1 to 2% over 10 years. We can say that by treating them, we are curing them, but even if you don't treat them, they are fine. So low risk patients, generally we keep an eye. Especially the more elderly they are, the less is the chance that they should be subjected to any treatment. Intermediate risk, if they are young. Young is categorized in oncological terms as anybody under 65 is young, anybody over 65 is, we tend to say that they are old. Does depend with respect to their, if somebody has got a cardiac history, diabetes and everything, then even a 60-year-old probably is physiologically 70-year-old. So taking everything else away, age group wise, we tend to say under 65 and above 65. So intermediate risk, under 65, we try to cure them of the cancer. Above 65, we can say, does this patient need curing or not? Or there are other reasons why his lifespan might be short. And high risk and very high risk, almost we tend to treat with the objective to cure in almost all the patients. What are the modalities? The modalities are generally two ways. Either you take it out, which is removal of the prostate, or you cook it, in that you heat up the prostate, whether you use radiotherapy standard or proton radiotherapy, or you use any focal radiotherapy, which might be either HIFU, high intensity focused ultrasound scan, or any of them. To cook, you heat up the prostate cancer so that the cancer cells die.
Right. Are there any medications that are also given? What is the hormonal element in this particular cancer?
So from 1941, there are only few Nobel Prizes in urology. And one of the first Nobel Prizes was for detecting that, in that prostate cancer can be controlled by ADT, which is androgen deprivation treatment, or by castration. So if you cut off their hormone supply, testosterone supply, they worked out that the prostate cancer can be controlled. This is in 1941. So right from 1941 until 2015, more than 6-7 decades, nothing changed in prostate cancer. Every patient from 1941 until 2015, if they have developed a cancer that has already spread away from the prostate, which seems to be around 50 to 60% of the prostate cancers in India, all of them had hormone treatment, which is cutting off the testosterone supply. How we achieved that, whether it was 3 monthly injections or by doing an operation on the testicle or 1 monthly injection, the objective was to suppress the testosterone. In 2015, groundbreaking research showed us that if we add in oral tablets, we were doubling their lifespan. So if I was saying that somebody was alive for 3 years, we were getting up to 6 years. And this is oral medication that is taken on a daily basis with minimal side effects, has almost doubled the lifespan of this cohort of patients. So currently we have got 2 molecules. Soon we'll be having 3 molecules in this area, which will control the prostate cancer better. So these are hormone control. So going back to the question that you raised, hormones, 90% of the testosterone is produced by the testicle. And these injections that have been there since 80s to control, we were controlling the 90%, but the 10% was there. That's one. And second, cancer cells are quite intelligent. If you don't give them testosterone, they manufacture their own testosterone. So these tablets are super androgen deprivation. So they not only block the testosterone from working, they also stop the cells from making their own testosterone. So that's the reason we are getting this very good outcomes, very good response. These are still hormone treatment, these are still castration treatment, but much more effective.
So is it a bit like how they give tamoxifen in breast cancers after the treatment for the rest of their lives? Is it also to be taken?
Yes.
Forever?
So these cancers, when they have already gone away from the prostate, generally the treatment is for lifespan. So you give it as long as it works. And the moment it stops working, then you choose second line treatment. The moment it stops working, you go for third line treatment. But whenever the cancer is already away from the prostate, out of control, or when you are only trying to control can only be achieved by putting the medication all the time.
Right. What about other medications? Is there like targeted therapy or other immunotherapeutic modalities?
So this is probably the most exciting time to be in management of prostate cancer or any cancers, because now we are seeing the results of probably the last 30-40 years of research. In that, when we have been talking about precision oncology for too long, but we were just giving the same kind of treatment, though we were talking of precision oncology. Now we have come to precision oncology. So what we do is, when a patient has a prostate cancer, especially advanced one, we do mutational analysis to see what actually are the mutations that have caused this cancer. And now we have got drugs that go and just target that. So whatever the biological process that has caused these cancers, we are able to target them. And this is as good a precision oncology as it gets. Are we there yet? No, we are not there yet. The reason is, we know that in a prostate cancer, there are about 70 to 75% of the prostate cancers. We know the mutations that have caused it. But we have got only one drug which works on 10% of this currently. So we still have got another 60% of those mutations we know which have got the cancers, and we need to develop those targets so that in near future, I'm not talking of before I die or anything, in the near future, in the next 5 years, every time we diagnose a cancer, we say, because of this mutation, that's why we are giving this medication. So that is targeted therapy. And again, immunotherapy as well has come in a rapid way. Currently, we are using it in a much later stage of prostate cancer, mainly because of the expense element. Again, immunotherapy, what we see is that it doesn't work in all the patients, but when it works, it gives you a long-term outcome. In that, patients are off medication for 5 to 6 years. So it doesn't work in that many, but when it works, you have hit the jackpot. You have controlled the actual reason why they have got the cancer. That's why you're getting long-term benefits. So cancer treatment, probably this is the most, I wouldn't use the word exciting time, because it is so much more beneficial. Rather than giving traditional chemotherapy, we are giving medication that only go and target those cells. Less side effects, much more efficacy, much better control over their life.
Absolutely. Is there anything else that you would like to add before we conclude the session, Doctor?
What I always say is, you use the word cancer is conquerable. I feel cancer is curable. You might say that both of them are the same. Curable is a much more easier understanding of it, and you feel whenever you want to conquer anything, you just think, oh God, it's such a big word, I don't want to even go down that. It's not a war. Whereas cancer is curable is, it's something that is easily doable for everyone to do. And the easiest thing to do is, please do get your health checkup done. Breast cancer is curable. Cervical cancer is preventable and curable. The biggest killer in India is preventable cancer and a curable cancer when we pick it up early. Colonic cancer is curable cancer when we pick it up early. Prostate cancer, 100% curable when we pick it up early. So do look out for any early signs. And I say, whether we can cure it or not is within your hands. Do go to your doctors early, do get your health screening done. And it does give us immense satisfaction curing a patient compared to controlling the disease. And it is a tenth of the cost in curing a cancer compared to controlling the cancer. So cancer is curable and it is within your hearts and your hands. Do get early screening done so that we can pick up these cancers early and we can cure you of your cancers.
One thing that I wanted to ask you when I didn't is about, you were talking about the lifestyle aspect. So apart from the screening, what else do you think people should do? What increases their risks of prostate cancer, and what elements of lifestyle changes have to be done?
So it's more of, at the start, I said we are seeing cancer more often in metropolis. And I also use the word saying that the more westernized we become, we inherit the diseases of the Western people. So there is very good evidence, when a Japanese person goes and settles in US, his risk of prostate cancer is not the same as the local. He will be at a lower risk, but his son will be at the same risk of the local population. What it shows is, whatever the benefit you are getting from your genetics is wiped out within one generation. So if I am more westernized, my son will be the person who will be paying for it, because I'm passing on those genetics onto him without the protection for the prostate cancer. Answering your specific question, what does Western lifestyle mean? Western lifestyle mean consuming a lot of easy calories, high calorie diet, high refined sugar diet, high oily diet, highly processed food, stored and frozen food that we keep reheating. Those are all the elements that cause cancer. And has that been proven? Very, very, almost, if you take the map of where the prostate cancer is and where there is more of this processed food, that's where it is. So if you decrease the amount of refined sugars, if you decrease the amount of fat in your diet, red meat in your diet, cholesterol, any of this, any high calorie intake, processed meat intake, all these things, there would be a decrease in the prostate cancer incidence. And more so doing the reverse way, more vegetable diet, freshly cooked diet, a bit more activity than what we are doing, that will be a prevention of it.
Absolutely. So thank you so much, Dr. Sanjai Addla, for this very illuminating discussion on prostate cancer. Yes, a diagnosis of cancer can be quite overwhelming, but even if you feel out of control, there are ways in which you can take charge. It may help. In fact, one of the best things that you can do is to learn as much as you can about your cancer. And the more you know, the more in control you are, and the more you can, even if you have not been diagnosed with cancer, being alert and attuned to your body can really help in detecting it early. And in many ways, it would also help in a cure. So, and we are here, as you know, 24/7 to support you in your awareness, in your diagnosis, screening, and treatment. So, no matter what the statistics say, there's always a way. So, stay safe, stay aware, and stay healthy. Till we meet the next time, thank you and namaste.